Good afternoon, everyone. I'm blessed today to be talking in front of esteemed panel. And thank you, Ahmedabad Orthopaedic Society, for the kind invitation. I'm so sorry that I'm just coming in the way of a nice UKR session, but I need to go back early. So I'm going to talk a little bit about valgus knee. I'm just happy that all of these surgeons or all of the faculties today are trying to admit that robotic is going to help a good surgeon. It is not a replacement or a substitute to a good surgeon. So nothing substitutes a skilled surgeon. That is what we need to understand. When we are talking about valgus knees, it is not a mirror image of a varus knee. That is very, very critical to understand. We deal with valgus knees only less than 10% of the cases that present to us for total knee replacement. Mostly the deformity is either congenital or secondary to osteoarthritis, rheumatoid, traumatic, or post-osteotomy cases. The clinical presentation is slightly different. These patients are less painful. They tolerate their pain well. The main problem that they present with is the medial instability, the lax MCL. If it is the lax in extension, it is the posterior capsule, which is lax. If it is lax in 30 degrees of flexion, it is a superficial MCL, which is lax. They also have external rotation deformity. So that is something that we need to understand clinically when we are examining these patients. Try to examine their foot progression angle, their thigh foot angle. They usually have compensatory pes plano valgus, which might need correction later on after the total knee arthroplasty. When you talk about radiology for valgus knees, it is important that we have at least 3 X-rays, the close-up and the alignment films. The close-up X-ray will tell you about the deformity in the tibia. Mostly the bone defects are central, they're not peripheral like the varus knees. And when you see their scanogram, they have significant lateral tracking of the patella, which is important to note. When you're talking about long leg films, we also need to understand there is sometimes these patients, they end up with extra-articular deformation. So the deformity is not only intra-articular, it is extra-articular in many patients. When you have a significant deformity, then you might need a CT scan to evaluate whether the deformity is from the femur or the tibia or the foot and ankle. The selection of implant for valgus knees is not a cruciate retaining always. Most of them, as I told you, have a lax MCL, so they might need a constraint which is higher than a cruciate retaining. Mostly a PS design works better. And when you have severe deformities with severe ligamentous issues, you can go ahead with a constraint condylar knee. That's the diaphyseal deformation that I'm talking about, which is always secondary to the soft tissue contractures. Even the external rotation torsion deformities in these patients is secondary to the soft tissue contracture. So when we are doing a manual knee in these patients and you're using an intramedullary femoral rod to get your distal femur resection, you might need to start slightly medial on your entry near the PCL insertion and not in the center of the intercondylar notch. So that is a technical message. When you have grades of valgus, there are 3 different grades of valgus with severe valgus deformities, as I mentioned, which is in less than 5%. With deformities which are more than 20 degrees, you might need to increase the constraint. This, of course, has been treated with rods on both sides, but recent literature suggests that these rods, they end up with stress fractures, either proximally or distally, so you prefer to have short, thick, cemented rods rather than trying to go right up to the isthmus on both sides. What are the intraoperative considerations for valgus knee? This is a 60-year female with significant tri-compartment osteoarthritis with a valgus deformity, has both pain and instability. The problem here is the distal femur wear as well as the hypoplasia of the femur. So when you are using your posterior reference line for the rotation of the component, it is not going to work. You will inadvertently end up with internal rotation of the femoral component. So either use your epicondylar axis or the cut surface of the tibia when you're using manual system. Ideally, a combination of these two is going to help you to set your rotation. Everyone has a different trochlea. When you see patella instability patients in younger age group, even the dysplasia in the trochlea is of different grades. So we cannot say that 3 degrees, 5 degrees or 0 degrees of rotation is ideal for every patient. When you study the CT scan of most patients, they will have a different trochlear morphology. So even some degrees of internal rotation will be required when you're balancing a knee in valgus. This, of course, when you're using a robotic system, the advantage is that you're using mapping. The intraoperative 3-dimensional picture that you create is going to help you set your rotation of the component. So that in severe deformity can help you when you're using technology. The biggest advantage of technology is the dynamic assessment of the soft tissue balance that the patient has. This patient has a 20 degrees valgus deformity with 20 degrees of hyperextension. The extension space is just 2 millimeters on the lateral side, 10 millimeters on the medial side. And the flexion space looks reasonably fine. So this is important to understand that every patient has a different soft tissue balance. You can make your cuts, adjust your implant position, but still if it is a rigid deformity, even after posterior tibial resection, it is very difficult to get the tight contracture on the lateral side correct. So then these patients are the ones who might require a soft tissue release along with your component positioning. Soft tissue contractures in a valgus knee, very important to understand that in a tight valgus knee on the lateral side, the structures which are inserting near the femoral epicondyle will lead to tightness both on flexion and extension. And so when you release this, you're going to release your extension and flexion space. And when you have structures which are inserting distally, that is the posterolateral capsule and the iliotibial band, these lead to tightness only in extension. So this patient had tightness only in extension, and so the IT band and the posterolateral capsule were released, but the posterior popliteus and the lateral collateral ligament were preserved, which we should possibly in most of the patients. And so that is a differential soft tissue release. Again, technology is going to help you with the dynamic assessment of the soft tissue. And that eventually is the key, because if you are able to balance this knee without major soft tissue release within 1 to 2 millimeters of the natural space that we all walk in, then these patients are significantly happy. When you talk about distal femoral wear, again, the most important thing is fixation of the implant. When you're using technology, you don't want any gaps beneath the implant. Cement up to 2 millimeters or 3 millimeters can take care, not beyond that. So that is critical when you are doing a technology-assisted valgus knee. The important thing is patella tracking. These patients have significant lateral patella tracking. So if you're doing resurfacing, it will help. You remove the lateral osteophyte and your tracking improves. Some patients, they do require lateral retinaculum release. Post-op, it is important that when you're correcting severe deformities, these patients may end up with stretch palsy of the peroneal nerve. At least 3% of the patients will end up with this. So we need to understand that you need to have little bit thinner inserts. Use a constraint. Don't use a thick insert and put a tight insert and then put the knee in extension. In post-op early recovery phase, you can put this knee in little bit of flexion to prevent the traction injury to the peroneal nerve. Some patients can end up with a stress fracture in the fibula. Most of the rheumatoid patients with valgus deformities can end up with a stress fracture, and they heal conservatively most of the time. Lateral uni, is there any role in 2026 for lateral uni? If the patient is old and has only uni compartment disease, then you can undergo a lateral uni. Fixed bearing implant is preferred because lateral joint is always lax as compared to the medial side. And that's a 78-year-old male with an isolated lateral compartment with less deformation of the extra-articular structures treated with a lateral uni. Again, another patient who is 70 years, lateral valgus knee, balanced with technology assistance, but I think the surgeon control of the soft tissue is the key. Recent literature is promising, but as I told you, we need more data, long-term follow-ups of these patients, and that will define whether we are going to use technology for our complex cases. So take-homes for arthroplasty in valgus knee. For 2026, patient-specific alignment is the key, especially for patients with less deformities. Use CPAC classification, try to maintain the joint line obliquity. Robotics will be the future, artificial intelligence will be the future, but you'll always need good surgeon who understands good soft tissue balance. When you're talking about femoral rotation, you can err on the internal rotation side and get away with good patella tracking. Tibia vara has been studied up to 7 degrees in attuned knee system from DEPU, and up to 3 degrees valgus is safe for patients who are following kinematic alignment. And remember, valgus is not a mirror image of the varus knee. Thank you.